Thank you very much. Thanks, Mort, for having me. So I was asked to talk about what the future holds for tyrosine kinase inhibitors, and I sort of figured by 3 o'clock on Saturday you would have seen a lot of waterfall plots. So I took the title literally, and I thought I'd talk about what the future of tyrosine kinase inhibitors holds. And after working for about a week and a half on this talk, I realized I had made the dullest talk known to humankind, and I apologize, but I'll try to make it relevant to your future, if not your current situations. So I'll first talk about Bruton's tyrosine kinase and Bruton's tyrosine kinase inhibitors. So ibrutinib, we know, is being developed by Pharmacyclics and Janssen right now. Pharmacyclics actually bought the platform from Celera in 2006, and in 2007, one of the investigators from Celera actually first published the chemical structure of ibrutinib along with some other BTK inhibitors. And not very long after that, Pharmacyclics published an abstract in ASH showing that it could kill B-cell lymphoma cell lines. Not long after that, it went into phase 1 trials, first in 2009. And it didn't take long before it started to create a lot of buzz. And in fact, already just 2 years later, Pharmacyclics partnered with Janssen. And you can read all about that on the internet. It's a tremendous amount of money. A few years after that, first publication in JCO, the FDA granted breakthrough therapy. Breakthrough therapy is brand new. It didn't exist before this. Granted breakthrough therapy designation for mantle cell lymphoma and Waldenström's macroglobulinemia, and then CLL. 2 more phase 2 trials in the New England Journal in CLL and mantle cell lymphoma, and a new drug application for both of those indications. Over 40 trials are on clinicaltrials.gov, and 3 publications in peer-reviewed journals so far. I wanted to present some of the ongoing studies that are either in cooperative group studies or are pivotal studies with the potential for FDA indication. So this is a phase 3 study in large cell lymphoma, taking R-CHOP plus or minus ibrutinib. It's exclusively in the non-germinal center subtype of large cell lymphoma. It's an international study, 800 patients. It's already ongoing and probably open at multiple centers. This is based on a phase 1 study that showed that R-CHOP and ibrutinib were safe in combination, and based on single agent data with ibrutinib demonstrating that ibrutinib is active specifically in the non-germinal center subtype of diffuse large B-cell lymphoma. That data is here. So the 1106 study has been open actually for a long time, and preliminary data were presented at ASH last year, just under a year ago. And you'll recall that in the activated B-cell subtype, there was about a 45% response rate versus almost 0%, I think it's 5%. In the germinal center subtype. Based on those results, the study actually reopened and is now open exclusively to the non-germinal center subtype of diffuse large B-cell lymphoma. The study was not designed as a pivotal trial, but neither were the mantle cell lymphoma or CLL study, so we'll see where that goes. In follicular lymphoma, this is not a study for indication, but it is an interesting study, and again, based on Dr. Fisher's comments, I'm not sure that he would use this up front outside of a clinical trial, but this is why we do clinical trials. And it's actually just recently opened, and it's accruing very well. In fact, it's hard to get your patients into the cohorts before they close. Previously treated follicular lymphoma, this is specifically in the alkylator or the chemotherapy and rituximab. So basically, all patients have to have received at least 2 prior lines of therapy. The last line has to be rituximab and chemo, and then they have to have progressed, they have to be refractory. These clinical trials are challenging to accrue to because the patients have to be refractory to everything, but they have to be healthy enough to go on a clinical trial. So it's a challenging patient population to accrue to. Nonetheless, it's accruing, and it will be completed in 2016. Mantle cell lymphoma, you already are aware of a lot of the mantle cell lymphoma data in relapsed mantle cell lymphoma. There is an upfront study looking at bendamustine rituximab plus or minus ibrutinib, and it's an international study, 520 patients. And there is one previously treated mantle cell lymphoma study a randomized phase 3 study outside of the US, so Europe and South America, comparing it to temsirolimus, where temsirolimus is approved, not relevant in the United States, but relevant to everyone from outside of the United States. First line in CLL in combination with BR, or randomized phase 3, BR plus or minus ibrutinib. This is specifically in older patients over 65, untreated CLL. It's ongoing and accruing very well. Another alliance study, which has not yet started to accrue, but is also an attractive study. This is actually looking at single agent. It's a 3-arm study of rituximab plus bendamustine versus ibrutinib versus rituximab plus ibrutinib. And it's an attractive study specifically in patients over 65. Also a big study, and it's at all alliance sites in the United States. Actually, I think it's an intergroup study. Previously treated CLL, there are multiple phase 3 studies. As you know, the new drug application has already been submitted for it, a single agent in CLL. I think that it will be interesting to see how insurance companies interpret the single agent phase 2 data with the context of ongoing phase 3 studies in a slightly different patient population. So this one is in combination with BR. There's another one compared to ofatumumab, or in combination with ofatumumab. And then finally, Susan O'Brien mentioned this one earlier today, a single agent phase 2 study in the 17p deleted CLL, which is already closed. So this is my art. These are sort of some of the history of studies in ibrutinib. You can see this was a phase 1 study, and then there are multiple phase 2 studies. The red lines are sort of my predictions for when the earliest theoretical time that we might see an indication. So potentially sometime this year or early next year in relapsed CLL and mantle cell lymphoma. No new drug indication application submitted for Waldenstrom's yet, despite the breakthrough therapy. And then potentially upfront in upfront in CLL based on the 115 study, and relapsed refractory diffuse large B-cell lymphoma based on 1106, relapsed refractory follicular lymphoma, and then frontline mantle cell lymphoma in CLL. These are some challenges I think they face. One question is how the community will interpret, or how insurance companies, how their government will interpret patient selection data in the large cell lymphoma studies. These studies all require central pathology review. There's already enough debate about whether or not you can accurately subtype large cell lymphoma based on immunohistochemistry alone. These studies require central review for immunohistochemistry and gene expression profiling. How that applies in a community setting, nobody knows. And another question I think that's relevant is BTK, or Bruton's tyrosine kinase, or ibrutinib resistance. As you all saw in ASCO this summer, out of 10 patients with CLL that progressed on ibrutinib, 5 had specific new mutations. 4 of them were in the BTK gene in the ibrutinib binding pocket. 2 patients, one of them had a BTK mutation plus another activating mutation in PLC gamma, and the 5th also had an activating mutation in PCL gamma 2. In the diffuse large B-cell lymphoma patient population, it's very clear that certain genetic subtypes may do better than others, even within the activated B-cell subtype of diffuse large B-cell lymphoma. So how do we put all of this data together? It's probably different in different kinds of lymphomas. Understanding the resistance patterns in ibrutinib will allow us to better develop rational combinations in the future. Adverse events. So in all of these studies, there is a small but significant rate of bleeding. There's also a interesting phenomenon of leukocytosis that I think we're starting to understand. Nobody knows yet what the significance of this leukocytosis is. It will be interesting to see what happens when the drug is approved. Are people going to freak out when their patient's lymphocyte count hits 200 or 300 or 800? What do we do with that? So there will be, I think there will need to be a big educational campaign around what to do with it. I think we have to decide what to do with that. And then the duration of therapy. Some people have suggested maybe we could stop the drug. I think it's preliminary to suggest that. This is not like imatinib, where we're getting eradication of minimal residual disease. These drugs still result in a fairly low complete response rate. So stopping therapy at this point in time, I think, is unlikely. Future opportunities: untreated follicular lymphoma, untreated Waldenstrom's macroglobulinemia, and some of the other lymphomas I think are interesting. There's another BTK inhibitor now under the auspices of Celgene. Interestingly, this drug binds with greater avidity to BTK. There have been a few trials looking at it, a couple of ongoing phase 1b trial, 2 phase 1b trials actually. Those are the time points for accrual and expected when they're finished. Obviously, no clear pathway to approval yet. One of the challenges this drug will face is obviously it's going to be compared to ibrutinib, which is hard to do right now. PI3 kinase pathway. So this is the history of idelalisib. I don't know much about patents, but I looked, and this was the earliest patent I could find for a specific PI3 kinase delta inhibitor. And then a phase 1 trial was initiated in 2008. By 2009, there was already a very significant buzz around the drug. And Gilead purchased it. Again, you can Google and find out how much that deal was worth. It's pretty impressive. And Gilead only recently, actually, just a month ago, submitted a new drug application for indolent non-Hodgkin lymphoma based on the 10109 study that I'll show you in a little while. And then just 2 weeks ago, Gilead actually halted a phase 3 trial in CLL, rituximab plus or minus idelalisib, and crossed everyone over to the idelalisib arm. So we assume that the results were promising there. No new drug application yet, but that's obviously soon to come. 16 studies at least have been opened in clinicaltrials.gov, but still zero peer-reviewed publications. I think it's an issue. So this is the Cal 10109 study. It's, again, a challenging patient population, alkylator refractory, rituximab refractory. Nonetheless, the data that was presented at Lugano this summer showed a 53% response rate. So a very impressive response rate, not just in relapsed, again, I guess maybe to counter Dr. Fisher, I know it's not a debate, I'm not debating Dr. Fisher, but I will debate it a little bit. This is not just in relapsed non-Hodgkin's lymphoma, this is in refractory non-Hodgkin's lymphomas. So it's clearly a very active drug in that patient population. And that has prompted the initiation of 2 ongoing phase 3 trials, the 0124 and 0125 study, one of them with rituximab, the other bendamustine rituximab. And those are open and ongoing. Previously treated follicular lymphoma, there are, again, through the Alliance, similar to the upfront study, an exciting study, and similar study in mantle cell lymphoma with actually a randomized phase 2 component after the phase 1 arm. Previously treated CLL, this is the study that was halted and is closed to accrual now. We look forward to those results very soon, I hope. I'm sure it will be exciting. And an ongoing phase 3 study in CLL, similar to the other one, bendamustine rituximab, and then another one with ofatumumab. So this is my art and potential approvals for idelalisib in the very near future in relapsed refractory indolent lymphomas, not just one subtype of indolent lymphoma, but and CLL, and then another phase 3 trial that may expand the indication. We'll see. Future adverse events. So there's some hepatic toxicity in all of the abstracts. Interestingly, the abstracts suggest that the hepatic toxicity is a little bit more common in the lymphoma patients than the CLL patients. No idea why that is. Again, the same issue with lymphocytosis. Mechanisms of resistance obviously are of critical importance, but we have no idea why people become resistant to the drug. PI3 kinase mutations are among the most common mutations in solid tumors, but they don't exist at all in lymphoma, curiously. Future opportunities similar to ibrutinib novel combinations. I think this is ibrutinib-resistant patients. Dr. O'Brien mentioned that this morning, and moving them up front. There's another PI3 kinase inhibitor. This one is not specific just to the delta isoform, but is a gamma delta PI3 kinase inhibitor. There are ongoing phase 1 and phase 2 studies, and that's sort of their timeline. Obviously, it's going to be compared to other PI3 kinase inhibitors because it's inhibiting more isoforms. There might be a little bit more toxicity. On the other hand, it might be more effective. We don't know at this point. So sick, there are no beautiful sick drawings. I think fostamatinib was the initial hope, but I couldn't find a slide from Rigel, so this is sick. There is a SYK inhibitor in development through Gilead, which provides a, if one company has two inhibitors, they can potentially combine them, which is a huge advantage as opposed to having to get two unapproved drugs together in the same patient population. So this is potentially the most exciting thing about this opportunity here. There's an ongoing phase 2 study by itself, as well as an ongoing phase 2 study in combination with idelalisib, which I think is obviously very exciting. And we look forward to those results. Obviously, it will be compared to fostamatinib. Fostamatinib, although it did actually have activity in CLL, it had like a 55% response rate. And then they moved on to study it in T-cell lymphomas where it wasn't as effective, and then in large cell lymphoma there was a study, but I haven't seen anything more about that, and there are no ongoing studies in clinicaltrials.gov. So these are my conclusions overall. Potential near-term approval for ibrutinib and idelalisib in multiple histologies. There are multiple pivotal trials underway. All of these trials, if you combine all of these trials together, it adds up to about 5,000 patients from 2009 up through about 2017, which is a little bit surprising, right? So that's 8 years with lymphomas that happen in about 50,000 people a year in the United States. So it's, despite the fact that these drugs are moving at record pace, you could argue that they could still be going much faster. There's unfortunately still very limited data in peer-reviewed journals. I think that's about to change, hopefully. And I think all of the opportunities to improve on these drugs that are already incredibly active depend on our understanding of resistance. And so far, that's still a little bit unclear. Thank you very much.